Hello, my name is Eric.
Hi,
Your name is
Kyungmi.
Kyungmi. Nice to meet you.
Nice to meet
I'll
you
be
too.
your provider today. And I hear today you're here for your physical examination. Is that
Yes.
correct?
Yeah.
All right, great. So before I begin my examination, I have to make sure that I ensure my patient privacy, make sure that the lights are well lit, and that I clean my hands before I see this patient. So, looking at this patient, first I would obtain a chief complaint, do a HPI where I utilize the PQRST mnemonic. I would obtain a list of current medications, allergies, past medical, surgical, social, psychosocial, and family history. I would also do a review of systems and also look at healthy age appropriate maintenance issues. And then I would obtain vital signs and also do a visual acuity test so that we can assess for cranial nerve 2. So, generally, looking at this patient, she's well appearing, well nourished, and no acute distress. She has good posture. Weight is appropriate for her height. She has a good BMI. Skin color is appropriate. And there's no obvious signs of distress at this time. So we'll move on to the cranial nerve assessment. So cranial nerve 2, we had that with the Snellen chart. We assessed for visual acuity and noted the patient has 20/20 vision bilaterally uncorrected without any corrective lenses. We would make sure we assess for cranial nerves 3, 4, and 6 by having the patient test for ocular motor function. So follow this light without moving your head. Great. And look behind me. Great. And then tell me when you can see my fingers.
No.
Okay. Tell me when you can see my fingers.
No.
Great. I'm also going to assess your pupillary response. Look straight at me. I'm going to shine a light in your eye. Great. Great. So pupils are equal reactive to light and accommodation to both consensual and direct light. I'm going to look at your eyes, look at her conjunctiva and her sclera, and note that the conjunctiva are pink and palpable and sclera are anicteric. There is no discharge, swelling noted around her eyelids. And then I'm going to assess her eyes with a fundoscopic examination. So I would turn off the light, and then I would normally I would turn off the light and examine her eyes with the fundoscope. So looking inside her eye, I would note that there are normal blood vessels, a visible disc margin, positive red reflex, and no hemorrhage noted inside her eyes. I would examine her ears and note that first I would have to palpate her tragus and her mastoid on both sides and note any tenderness.
No.
Okay, great. I would pull her pinna up and back to look inside her ears on both sides. And note that the auditory canal is clear. There's minimal cerumen impaction. Tympanic membrane is pearly gray, shiny. There's no bulging or retraction noted, and auditory canals are clear. She can follow my instructions. She can hear me pretty well. I would assess her sinuses, so I'm going to palpate her maxillary ethmoid and her frontal sinuses, and note that they are non-tender to palpation. I would also look at her nose and note that it is straight. There are no obvious signs of discharge. Looking inside her nose, I would note that the nasal turbinates are red. There's no obstruction, and the septum is non-deviated. I would next move on to her oral examination. So her lips, gums, and say ah.
Ah.
Great. Her lips, gums, and oral mucosa are pink, moist, non-edematous. There are no lesions noted to the floor of her mouth or inside of her mouth. She has good dentition. I'm going to assess for her swallowing. So go ahead and swallow. Trachea is midline. Thyroid is not visible or palpable upon examination. I would also assess her lymph nodes. So then I would palpate her occipital, posterior cervical, anterior cervical, submandibular, submental, supraclavicular, and infraclavicular lymph nodes. And note that there's nothing that is palpable. There's no tenderness noticed with my examination. I would assess her neck. So I'd have you turn your neck side to side, your head side to side, up and down, and note range of motion. So the neck is supple and there's good range of motion. I would assess for carotid. Carotid bruit with the bell of my stethoscope. So no carotid bruit noted upon examination. Looking at her skin, she has good skin turgor, good elasticity. There are no obvious lesions, masses, no abnormal moles or pigmentation on her skin. Her hair is clean and evenly distributed. Upon palpation of her skull, there are no depressions, nodules, or masses noted. Looking at her face, it is symmetrical. She appears relaxed. There are no obvious signs of distress noted. And looking at her hands, her nails are clean. Cap refills less than 3 seconds. And there's no clubbing noted or cyanosis noted to her fingers. I will actually jump to the cranial nerve assessment because I skipped that part. So I will finish where I left off, where after ocular motor function, we'll assess for cranial nerves 5 and 7. Can you feel me touching you here?
Mm-hmm.
Great. I'm going to have you smile for me. Raise your eyebrows, puff out your cheeks, clench your jaw. Great. And then I would assess for hypoglossal or 9, 10, and 12. So go ahead and stick out your tongue. Say ah. Turn your tongue side to side. Great. And then note that her uvula is midline, tongue is well papillated, tongue is midline as well, oral mucosa is pink, and we would use a tongue depressor to assess for a gag reflex, but we won't do it for this patient at this time. Now we'll assess for cranial nerve 11. So I'm going to have you shrug your shoulders, push your face against my hand, and then this way. Great. So cranial nerves 1 through 12 are intact. I'm going to resume my examination and assess her posterior chest and note that upon inspection, the spine is vertically aligned. Shoulders and hips are of the same height. There are no abnormal masses, lesions, or bumps noted. Spine is tender, non-tender to palpation. I would next begin by doing tactile femidus. So go ahead and say 99.
99.
Again.
99.
Again.
99.
Tactile femidus is equal bilaterally. Then I would begin percussion of the lung fields. So I'm going to percuss on both sides to know areas of dullness and resonance. And then I would assess for diaphragmatic excursion. So I'm going to have you take a deep breath and exhale. Hold. And I would note the spot. I would percuss down her left spine to know where dullness begins. And then from there, I'm going to have you take a normal breath and then inhale and hold. And from that spot that I marked, I would percuss down to where the dullness stops. And you can relax. So that distance between those 2 points that I marked should be approximately 3 to 5 centimeters apart, and you do that on the right side as well. From there, I would assess for respiratory excursion. So I'm going to have you take a deep breath. Great, hold. So you can relax. My thumbs moved apart about 4 centimeters, which is normal for this person as well. I'm going to auscultate her lung fields with the diaphragm of my stethoscope. Deep breath. Great, deep breath. Deep breath. Deep breath. Deep breath. Okay. So lung sounds are clear bilaterally. There's good aeration to all of our lobes. There's no adventitious lung sounds heard over auscultation. I'm going to pat both your right and your left CVA regions. You can tell me if there's any pain or tenderness there.
No pain.
So negative for CVA tenderness. I would come over to the front side, inspect her anterior chest. Note that she is relaxed. She's not using any accessory muscles. There are no abnormal lesions or masses noted. I would do tactile firmness again. So go ahead and say 99.
99. 99.
Great. So tactile firmness is equal bilaterally as well. I would auscultate her lung fields first with the diaphragm of my stethoscope. Sorry, deep breath. Okay, so lung sounds are clear bilaterally. There's good aeration to all of her lobes. No adventitious lung sounds are heard. And then I'm going to auscultate for her heart sounds as well. And note that her to the right sternal border at the second intercostal space is her aortic, and then pulmonic is at the left second intercostal space to the left sternal border. Erb's point is at the third intercostal space to the left sternal border, and then the fourth intercostal space of the left sternal border is the pulmonic, and then is a tricuspid, I'm sorry, and then the fifth intercostal space to the left midclavicular line is the mitral valve. And then I'm going to go ahead and lean forward a little bit. Great. So the patient has normal heart sounds. S1 and S2 are heard. No S2, S3 or S4 sounds. No murmurs, rubs, gallops, or clicks are heard as well. Using the bell of my stethoscope, I would listen for any murmurs. Okay. While this patient is, so I did not hear any murmurs. While this patient is upright position, I would assess for her pulses. So I would check her peripheral pulses, her popliteal pulses, posterior tibial, and dorsalis pedis pulses, which are a regular rate and rhythm. I would next have the patient lay on her left side. And this is the left lateral recumbent position. I would palpate at the fifth intercostal space, left midclavicular line for the PMI, and this point of maximal impulse is regular and normal and palpable. I would also have the patient sit up so I could take a listen to her neck and make sure that we don't hear any carotid bruit. So no carotid bruit heard over auscultation. I'm going to have you lie back again and we'll continue our examination. So I'm going to begin the abdominal assessment where I'm going to have this patient lift her shirt up and expose her stomach. We would note that upon inspection, the skin is free of any lesions, masses, striae, or abnormal scarring. There are no masses noted. I would begin with auscultation. So I would take a listen with the diaphragm. Okay, and note that abdominal sounds are normal active. I would listen with the bell of my stethoscope for any kind of bruit. So aortic, renal, iliac, femoral. I would also note that there are no bruits in those regions, and I would do a light palpation first. So Kyomi can tell me if there's any pain or tenderness when I palpate. No pain or tenderness? Okay, so no pain or tenderness to light palpation. I would begin by assessing Murphy's signs. So I'm going to have you take a deep breath, inhale, and hold. Any pain or tenderness? Exhale. So upon palpation to our right upper quadrant, there's no pain noted, which is a negative sign for Murphy's sign, which is an indicator of appendicitis. So next I'm going to assess for her liver, palpate her liver and her kidneys. It's going to be right under the right costal margin and at her flank region. I would do this on both sides. Go ahead and inhale and palpate for any liver edges or any organomegaly and kidneys which are non-palpable at this time. You can relax. At this point, seeing this patient lie down like this, I could note that there's also no JVD or increased jugular venous pressure. It is at the sternal angle at approximately 3 to 4 centimeters. And moving on to the next part of the abdominal examination, I would have you turn to your side again. And I'm going to flex your right hip backwards. Any pain or tenderness?
No.
Great. And then I'm going to lie back again. I'm going to have you bend your hip up like this. And I'm going to turn side to side. Tell me if there's any pain or tenderness.
No.
So this is the obturator as well as a McMurray's test. So given that I did the psoas and the obturator test, those are signs of appendicitis. I'm going to retract what I said earlier about the right upper quadrant, and that Murphy's sign was for cholecystitis instead. So these tests for appendicitis, and she didn't exhibit any pain, which is negative. The McMurray's test was that same motion that I did in that test for any kind of meniscal damage of the knee. Also note that I'm going to palpate around her umbilicus and feel for any abnormal pulsations or masses, which there are none of, meaning that there is no sign of a AAA or abdominal aortic aneurysm. Next, I'm going to move on to, I'm going to have you sit up actually, thank you, Pingmi, and begin the neuromuscular examination. So I'm going to have you first, we're going to test for cerebellar function. I'm going to have you touch the tip of your nose and touch my finger in multiple spots. Great. And I'm going to have you do rapid alternating movements. And then heel to shin on both legs. Great. And then the last test, we'll do Romberg's after, but we're going to test for sensation. So I'm going to use a pointy and dull tip of my hammer. And you can tell me if you feel it dull or sharp, okay?
Okay.
This is what dull sharp feels like, and this is what dull feels like, okay?
Okay.
So
Oh, sure. I don't know.
try it again.
Dull.
Mm-hmm.
Dull. Sharp. Sharp.
Okay.
Dull. Dull.
Great. So that is normal. Normal sensation. I'm also going to test for her sense of vibration. So using the tuning fork, I'm going to put this against both of her wrists and her big toes, and you can tell me if you feel it, okay?
Okay. Yes. 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 Yes.
Okay, so vibration's intact. I'm going to assess for her deep tender reflexes at this time. And now I'm going to start with her brachioradialis. So, good. And then her biceps. Okay. Okay. Tricep. Okay. Okay. And then patellar. Great. Great. And then you bend your legs a little bit and do Achilles. Okay, so deep tender reflexes are intact as well. I'm going to assess for Babinski response. So, okay, this goes under her feet in the plantar region. The patient had a plantar flexion, which is normal response for an adult. I'm going to assess for range of motion of her upper extremities first. So I'm going to have you, while you sit there, have you abduct your arms out like this and back down. I'm going to have you raise it back up in this position, push against me, pull against me. Great. And then I'm going to have you flex your elbows up and back, push against me, and pull back against me. Great. Flex your wrists, and then grab onto my hands. Nice tight squeeze. Very good. So the patient is exhibiting active range of motion to her upper extremities with a strength of 5 out of 5. And let's do her lower extremities now. So I'm going to have you push up against me. Great. Push up against me. Great. And then I'm going to have you flex your knees up and back. Great. And I'm going to have you flex your ankles and your toes. Push down the gas pedal. Pull up. Great. So this patient's also exhibiting active range of motion to her lower extremities with a strength of 5 out of 5. I would also, before you lift him, I'm going to palpate your joints. So her neck, her shoulders, elbows, wrists, knees, ankles, and feet and toes are free of any joint tenderness or swelling. So I'm going to have you stand up. I'm going to have you stay still without moving. Close your eyes. And this is the Romberg's test. You can open your eyes. So this patient passed the Romberg's test because she's not having any variously large swaying motions noted. And then I'm going to have you do a Phelan's test. So I'm going to have you first hold your hands up like this, or like this works as well, in a 60-second interval. And if the patient develops any kind of tingling or numbness sensation to part of her third digits, then that would be an indicator of carpal tunnel syndrome. Okay, now I'm going to have you relax your hand. I'm going to tap the median nerve here. Any pain or tenderness?
No.
Any pain or tenderness here?
No.
So this patient is also negative for Tinel's test because that indicates that if there's any pain elicited to the first or third digits, then that would be a positive response. Now we'll move on to your gait. So I'm going to have you stand, and I'm going to have you walk towards the wall. Great. And then walk towards me, heel to toe. And then walk just on your toes, and then just on your heels. Great. Have you do a squat. Great. And then I'm going to have you turn over and touch your toes. So examining her spine, any pain or tenderness?
No.
A scapular rise to the same height. Spine is non-tenderness of palpation, and there's no abnormal curvatures. You can stand up. Next test I'm going to do is the McMurray's. We did the McMurray's test, so we will move on to the Apley scratch test. So I'm going to have you scratch your back with both your hands, and then the other way. And I'm going to have you do a beer can test now. Keep your arms up like this and pretend like you're dropping 2 cans of beer. Great. Keep your arms up without moving, and then you can let go. So those are all tests for, so that was the Apley scratch test, the beer can test, and the drop arm test, which tests for a rotator cuff tear or supraspinatus muscle tears. Next, I'm going to do the apprehension test. So the patient is going to relax her arms like this. I'm going to have you bend this way. Any pain or tenderness?
Mm-mm.
Any pain or tenderness?
No.
Great. So the patient passed that apprehension test as well. And then I think we forgot to do the anterior drawer test, and also we'll do that first. So I'm going to anchor her right leg and pull this leg forward. There's no hinge-like movement, and the patient did not exhibit any pain, which are negative signs for that test. So now we're going to the valgus and the varus tests. So I'm going to push out like this. Any pain or tenderness?
No.
I'm going to come in on this side and push out like this. Any pain or tenderness?
No.
Okay. So those are negative tests for the valgus and the varus, and those are indicators of medial and collateral ligament tearing or deficiencies. I'm going to have you sit up, and I believe this concludes our presentation.